Welcome to Unit 4, Cardiac Assessment and Dysrhythmias Overview. In this unit, we'll focus on how to assess cardiac rhythm, recognize dysrhythmias, and connect ECG findings to patient perfusion and clinical decision-making. This content builds directly on Unit 3, so it's important to review Units 3 and 4 together to see how rhythm, cardiac output, and perfusion all work together. As we move through this unit, keep the patient in mind. Always assess clinical stability first, then use telemetry and ECG data to guide safe nursing actions. Let's get started.
Let's get started. This slide reviews assessment and perfusion basics, which are essential when evaluating patients with dysrhythmias or suspected cardiac instability. The earliest organs affected by decreased cardiac output are the brain and the lungs. Because of this, early signs of hypoperfusion often include altered mental status, decreased LOC, and decreased oxygen saturation. A key concept to remember is that hypoperfusion occurs before hypotension. Blood pressure can remain within normal limits even when cardiac output is falling. If you see changes in mentation or a drop in oxygen saturation, think decreased cardiac output first, even if the blood pressure looks okay. The next section reinforces an important priority. Always assess the patient before the monitor. The ECG shows electrical activity only. A visible rhythm on the monitor does not guarantee that the heart is producing an effective pulse. Always correlate the rhythm strip with pulse quality, blood pressure, mental status, and oxygenation. Remember, a rhythm on the monitor does not equal effective circulation. Finally, this slide reviews a quick heart rate calculation used in urgent situations. Count the number of QRS complexes in 6 seconds, which is 30 large boxes, and multiply by 10. This rapid method supports bedside decision-making, especially when assessing unstable patients, and helps you quickly identify rates that may compromise perfusion.
Let's practice a little more on how to calculate heart rate using an ECG strip, which is a skill you'll use frequently in both exams and clinical practice. There are 2 common methods shown here, and it's important to know when to use each. First is the large box method, which works best when the rhythm is regular. You count the number of large boxes between R waves. As a quick reference, every 5 large boxes equals about 60 beats per minute. 4 boxes is about 75 beats per minute. 3 boxes is about 100 beats per minute. This method is fast and useful when the rhythm is steady and consistent. Next is the 6-second strip method, which is especially helpful for irregular rhythms, such as atrial fibrillation. To use this method, identify 30 large boxes, which equals 6 seconds. Count the number of QRS complexes in that span and multiply by 10 to estimate the heart rate. Remember the timing rule shown on the slide. 1 big box equals 0.2 seconds. 5 big boxes equals 1 second. 30 big boxes equals 6 seconds. The examples at the bottom of the slide give you practice estimating heart rate when beats fall between 3 and 4 large boxes, reinforcing that heart rate is often an estimate, not an exact number. The key takeaway is to choose the method that fits the rhythm you're seeing. Use the large box method for regular rhythms and the 6-second strip method for irregular rhythms, always focusing on accuracy and clinical relevance.
Let's move on. This slide reviews ECG fundamentals and introduces heart blocks, with an emphasis on how conduction abnormalities affect perfusion. We'll start with first-degree AV block. This rhythm is characterized by a prolonged PR interval, but there is 1 P wave for every QRS complex. Even though conduction through the AV node is delayed, all impulses still reach the ventricles. Because there are no dropped beats, first-degree AV block is usually asymptomatic and often requires monitoring only. The key point to remember is that this rhythm is generally benign unless it progresses or the patient becomes symptomatic. Next, let's focus on the QRS complex, which is one of the most important ECG waves to recognize. The QRS represents ventricular depolarization, which directly corresponds to ventricular contraction and cardiac output. If the ventricles do not contract effectively, there is no forward blood flow, meaning no perfusion. This is why the QRS complex is the most critical wave on the ECG from a nursing perspective. Finally, we'll look at third-degree, or complete, heart block. In this rhythm, there is no relationship between P waves and QRS complexes, and you will often see more P waves than QRS complexes. The ventricles rely on a ventricular escape rhythm, which produces some cardiac output, but it is significantly reduced. Because perfusion is compromised, patients are at high risk for hypotension, syncope, and instability, and a pacemaker is typically required. This slide reinforces how identifying conduction delays and blocks on the ECG helps nurses anticipate changes in cardiac output and patient stability.
Let's move on. This slide addresses a very common and important question. What do we do when we see artifact on telemetry? Telemetry artifact occurs when the monitor picks up non-cardiac signals, such as patient movement, loose or dried electrodes, muscle activity, or electrical interference. These signals can make the rhythm look abnormal even when the patient's heart rhythm is actually stable. When you see a rhythm that suddenly looks chaotic or concerning, the first step is not to assume it's real. Always assess the patient first. Check for a pulse, assess mental status, blood pressure, oxygen saturation, and ask how the patient is feeling. If the patient is awake, talking, and hemodynamically stable, what you're seeing on the monitor is very likely artifact, not a life-threatening dysrhythmia. Next, troubleshoot the equipment. Check electrode placement, replace loose or dried leads, and ask the patient to remain still if they were moving. The key nursing takeaway is this: treat the patient, not the monitor. Telemetry supports assessment, but it never replaces clinical evaluation. Recognizing artifact prevents unnecessary interventions and ensures patient safety.
Let's move on. This slide reviews common causes of dysrhythmias and reinforces key priorities in atrial fibrillation management. We'll start with electrolytes and dysrhythmias. Potassium and magnesium are essential for normal cardiac electrical activity. When levels are low, often due to dehydration, diuretics, or poor intake, the risk of dysrhythmias increases. This is why monitoring electrolytes is a critical nursing responsibility in cardiac patients. The middle section connects LDL cholesterol and cardiac risk. Poor diet, inactivity, and chronic stress contribute to elevated LDL levels. Over time, high LDL promotes atherosclerosis, which reduces coronary blood flow, causes ischemia, and increases the likelihood of dysrhythmias. The final section focuses on atrial fibrillation priorities. In AFib, the loss of effective atrial contraction, often called loss of the atrial kick, leads to blood stasis in the atria. This significantly increases the risk of clot formation and stroke. Because of this, the primary priorities in AFib management are rate control to support cardiac output and anticoagulation to prevent stroke. Among all concerns in AFib, stroke prevention remains the most important. This slide highlights how underlying factors like electrolyte imbalance and atherosclerosis contribute to dysrhythmias, and why recognizing and addressing these risks is essential to safe patient care.
Let's move on. This slide focuses on post-cardioversion care and ECG recognition, which are critical for preventing complications after restoring a patient's rhythm. After cardioversion, there is a high risk of atrial fibrillation recurrence, especially in the early post-procedure period. Because of this, continuous cardiac monitoring is essential to quickly identify rhythm changes or deterioration. Even when cardioversion is successful, patients are often continued on anticoagulation therapy. This is because atrial function may remain impaired for a period of time, and the risk of stroke does not immediately resolve. Close observation allows nurses to recognize complications early and intervene promptly. The lower portion of this slide reviews key ECG characteristics of atrial fibrillation. AFib is identified by no visible P waves and an irregularly irregular rhythm. Because the atria are not contracting effectively, there is a loss of atrial kick, which leads to blood stasis and increases the risk of clot formation. Management priorities for atrial fibrillation include rate control to support cardiac output and anticoagulation to prevent stroke. This slide reinforces that restoring rhythm is only part of care. Ongoing monitoring and stroke prevention remain essential nursing priorities.
Let's move on. This slide reviews electrical therapy, specifically cardioversion and defibrillation, and it's important to clearly distinguish when each is used. We'll start with cardioversion. Cardioversion is used for unstable tachycardias when a pulse is present. Common indications include atrial fibrillation with rapid ventricular response, REVR, supraventricular tachycardia, SVT, and unstable ventricular tachycardia, VT, with a pulse. Cardioversion delivers a synchronized shock, meaning the shock is timed with the R wave of the QRS complex. This synchronization is critical to avoid the R on T phenomenon, which could trigger ventricular fibrillation. The goal of cardioversion is to restore a normal rhythm while maintaining circulation, so careful timing with the cardiac cycle is essential. In contrast, defibrillation is used in cardiac arrest situations when there is no pulse. Defibrillation delivers an unsynchronized shock and is performed immediately. Defibrillation is indicated for ventricular fibrillation and pulseless ventricular tachycardia. In these rhythms, there is no effective cardiac output, so restoring organized electrical activity is the priority. In cardiac arrest, survival depends on early CPR and rapid defibrillation. These interventions are the primary actions to restore cardiac output and perfusion. The key takeaway from this slide is to always ask two questions first. Does the patient have a pulse? And is the rhythm organized or chaotic? The answers guide whether cardioversion or defibrillation is the appropriate intervention.
Let's move on. This slide focuses on pacemaker indications and the priority checks nurses perform to ensure the pacemaker is functioning correctly. Pacemakers are most commonly indicated for third degree or complete heart block, where there is no coordinated electrical conduction between the atria and ventricles. In this situation, the heart cannot maintain adequate cardiac output without electrical support. Another key indication is symptomatic bradycardia that does not respond to medications. When a slow heart rate leads to decreased cardiac output and symptoms such as dizziness, syncope, or hypotension, pacing may be required to restore perfusion. After pacemaker placement, ongoing monitoring is essential. Nurses should monitor heart rate and rhythm to ensure pacing is appropriate for the patient's condition. It's also important to confirm electrical capture, meaning the pacemaker's electrical impulse is successfully triggering ventricular contraction. Electrical capture without mechanical contraction would not support perfusion. In addition, nurses must verify proper sensing, which ensures the pacemaker correctly detects the patient's intrinsic cardiac activity and does not pace unnecessarily or fail to pace when needed. These priority checks help maintain effective cardiac output, reduce complications, and support patient safety following pacemaker implantation.
On this slide, let's check a common post-procedure complication after pacemaker implantation: hematoma formation. After a pacemaker is placed, bleeding can occur in the tissue pocket where the generator sits, especially because many patients are receiving anticoagulation or antiplatelet therapy. This can lead to visible swelling, bruising, firmness, and discomfort at the insertion site. As nurses, one of the key priorities is frequent inspection of the pacemaker site. A hematoma may appear as increasing swelling, tight or shiny skin, expanding bruising, or pain that is worsening rather than improving. It's important to differentiate normal post-procedure bruising from a developing hematoma. Rapid enlargement, increasing firmness, or skin tension should raise concern and prompt immediate provider notification. Large hematomas can increase the risk of infection, lead displacement, and delayed healing, and in severe cases may require intervention or surgical evacuation. Nursing care includes monitoring vital signs, assessing pain, limiting excessive arm movement on the affected side as ordered, and closely observing patients who are on anticoagulants. The key takeaway is that early recognition and prompt reporting of a pacemaker hematoma are essential to prevent complications and protect patient safety.
Let's move on. This slide focuses on ventricular dysrhythmias and cardiac arrest, which are true cardiac emergencies requiring immediate recognition and action. We'll start with ventricular fibrillation, or VFib. In ventricular fibrillation, there is no effective cardiac output because the ventricles are quivering instead of contracting. Without intervention, this rhythm is fatal. Immediate CPR and rapid defibrillation are required to restore a perfusing rhythm and give the patient a chance of survival. Next is pulseless ventricular tachycardia, or pulseless VT. Even though the monitor may show an organized rhythm, there is no detectable pulse, making this a form of cardiac arrest. Treatment is the same as VFib, CPR, and defibrillation. This slide also highlights hemodynamically unstable rhythms, which include VFib, pulseless VT, AFib with rapid ventricular response and symptoms, and severe symptomatic bradycardia. Signs of instability include hypotension, altered mental status, chest pain, and shock. In any cardiac arrest scenario, CPR is the immediate priority. If the rhythm is shockable, defibrillation should be performed as soon as possible to maximize the chances of survival and return of spontaneous circulation. The key takeaway from this slide is that when there is no pulse or no perfusion, rapid action saves lives. Nurses play a critical role in recognizing these rhythms and initiating life-saving interventions without delay.
Let's move on. This slide focuses on coronary disease and post-procedure care, with emphasis on disease progression, immediate nursing priorities, and long-term risk reduction. We'll start with atherosclerosis, which occurs when lipids combine with fibrous tissue to form plaques that narrow coronary arteries. This narrowing reduces blood flow, leading to ischemia, which can trigger dysrhythmias and other cardiac complications. Next, we'll look at post-PTCA priorities. After a percutaneous coronary intervention, a key nursing focus is monitoring for bleeding at the access site. Because patients receive anticoagulation, their bleeding risk is increased. Early recognition and prompt management of bleeding are critical to patient safety. Finally, this slide highlights modifiable risk factors for coronary disease. These include diet, weight, hypertension, diabetes, and physical inactivity. Addressing these factors through lifestyle changes and medical management can significantly reduce future cardiac risk and improve long-term outcomes. The key takeaway is that coronary disease management doesn't end with the procedure. Ongoing monitoring and risk factor modification are essential parts of nursing care.
To wrap up, this final slide offers brief practice with common dosage calculations. Work through each question independently to strengthen both accuracy and confidence in medication math. Thank you all for your attention and engagement throughout Unit 4. In this unit, we focused on cardiac assessment and dysrhythmias, building on the cardiovascular concepts introduced in Unit 3. We reviewed how to assess perfusion, interpret cardiac rhythms, recognize dysrhythmias, and prioritize nursing actions in both stable and emergent situations. As you continue studying, think about how rhythm recognition, patient assessment, and timely interventions directly impact patient safety. If you have any questions, please feel free to reach out. Thank you again, and I'll see you in the next session.